Hello everyone, this is Yong-Suk Jo. In the previous session, I discussed immediate implant placement after extraction on mandibular molars. Today, I will discuss early, delayed, and late implant on mandibular molars. Okay, first I want to speak about the early implant placement on mandibular molars. Here is my classification, timing of implant surgery after extraction. Early immediate means place implant within 2 weeks after extraction, and early 2 weeks to less than 3 months. Delayed is 3 months to less than 6 months, and late means 6 months or more after extraction. Okay, depending on extraction time, we can see different condition of the extraction socket. Okay, sometimes we expect soft tissue healing, and when time passed long enough, we expect hard tissue healing also. What is the characteristics of early implant after extraction? In this time, within 3 months after extraction, soft tissue healing is almost completed. However, bone maturation is insufficient. Then, what is the indication of early implant after extraction? Many dentists like to place implant at this stage, about 1 to 2 months after the extraction. They says we can utilize maximum osteoblastic activity at this stage. Okay, about 4 to 6 weeks after extraction, here is the maximum osteoblastic activity. So when we place implant and do bone graft at that stage, we expect nice healing, bone healing, so we can utilize these natural advantages. However, I don't agree about this. Okay, I agree the fact that this is time of maximum osteoblastic activity, but I don't agree with this is optimal time to place implant. Instead, I prefer delayed implant. Indication of early implant is in this situation. It is indicated in a case where immediate implantation was possible after tooth extraction, but was not implanted immediately for some reasons. This is indication of early implant placement. I prefer delayed implant placement whenever possible. I will show my older cases which performed the early implant surgery in mandibular molars. It was 23 years ago. 2003, I had a patient who extracted the left second molar, and 1 month after the extraction, I opened the flap to place implant. Then I found the big defect at number 7 site. So for grafting, I couldn't place immediately, so I decided to do GBR first. At that time, even I harvest block bone from the mandibular symphysis area, and GBR was done. Okay, like this. Okay. After healing, 5 months later, nice bone was formed, and I can place implant. At the time, we preferred long implant, big and long implant. This is 14 years after operation. Implant is successfully maintaining in the mandible. Is this good job? Anyone looking at this case would agree that the treatment was overly too aggressive. Okay, I feel so. Okay, if I do manage this case again, I I would wait for spontaneous healing and place a short implant. Okay. If necessary, I will do minor graft. Maybe it is not necessary if I place implant about 6 months later. Just I open the flap after 1 month after extraction. That's why I have to do aggressive surgery. Okay, next case, it is 2010. I have another patient who extracted the right mandibular molars 1 month ago. And in clinical view, soft tissue is healed. However, in CT view, we can see insufficient bone healing. I opened the flap and I found no bone was there sufficiently. So I have to do immediate implant, no, not immediate, it is early implant. And I have to do GBR to cover the defect. Okay, standard GBR was done and submerged the implants. Because of pulling a buccal flap, there was a lack of keratine tissue. I have to do free gingival graft to increase keratine tissue. Okay, during the second stage surgery, I performed the FGG, and final outcome is here. The lower pictures 12 years later. We can see nice condition of bone and soft tissue. However, I have to spend a long time to finish the restoration, and patient received big surgeries 2 times. It is painful to patient. I think this case looks not bad if I see just the result. The process is not so effective. So no more I do such a strategy such as early implant placement. Many early implant cases will be a GBL case, and the surgery will be complex and takes a long time for total treatment time, and the patient must suffer the pain and pay much cost. So this is a very ineffective strategy. Then, what should you do when we extracted the teeth, and when is the best time? In previous session, I mentioned that Type 1A is the indication of immediate implant. In my current concept, I perform early implant placement only in very limited situation. Okay, except for Type 1 extraction socket, it is better to do delayed or late implant surgery. That means early implant indication is same as immediate implant. Okay, so it is very limited situation. Here are tips for early implant placement after extraction. Do not open the flap. It is like opening the lid of a pot before cooking is finished. Okay. In my previous and many current cases I see is early implant which combined with extensive GBR, because we open the flap too early. Okay. Select the final drill based on the bone quality at the apex. Many early cases, the coronal portion bone is very weak. However, the apical portion is normal or hard bone. So, to prep the osteotomy, consider density of the apical bone. Okay. And this is very important. Predict the bone height after healing and place the implant inside it. Okay. We can imagine how much bone will heal. Then your implant should be positioned within the expected bone. Okay. And better to place implant a little bit deep. Okay, about 5 millimeter from the gingival margin. Okay. Let me show a case of early implant placement. Here is a 64 years old male patient who extracted right second molar, mandibular molar 3 weeks ago. Okay, look at the panoramic image and let's trace the mandibular canal is here. Okay, mandibular canal is slightly away from the extraction socket, but it is less than 5 millimeter. That means it is type 1B extraction socket originally. Type 1A is the best indication of immediate implant. Type 1B, a little bit risky, but me, maybe I'm an expert, so I can do implant immediately in type 1B with careful surgery. So this is all same situation. Okay, I can do immediate implant. Then early implant is also possible. Look at the clinical pictures. Okay, the socket is incompletely healed. The soft tissue covered and it looks very weak. Bone is not regenerated yet. If I open the flap, this case will change as a GBR case. However, I didn't open the flap, okay? And perhaps osteotomy with a flapless surgery. After preparation, during the early immediate implant surgery session, I mentioned about how to select the implant during the immediate implant placement. Same principle can be applied in early implant surgery. I finished the osteotomy with a f4.5 by 12 millimeter long implant, long drill. Then, how to select the length of implant to be placed. Okay, my goal is to place implant about 5 millimeter deep from the gingival margin. So before select the implant, I measured the depth of osteotomy site. It was measured as 14 millimeter. Then, how long implant is better? Okay, if we minus 5 millimeter, available height is 9 millimeter. So we can select 8.5 or 7.5. Anything is fine. Okay, the short is fine. This case, I selected a XL implant 4.6 by 7.5. So I can place implant a little bit deeply. Okay, the depth looks about 6.0 millimeter. And I prepped osteotomy considering apical bone density. Okay, so I used the drill as a normal bone. Finally, I can get stability 20 Newton centimeter and ISQ value 67, 68. Here, I connected the 5 by 5 healing abutment. It is slightly under the gingival margin. It's no problem. Sometimes I connect 5, 5, 7 healing abutment. Okay, this is a POP radiographic images. Okay, as I planned, the implant was well placed. Here is 1 month follow-up. Soft tissue healed well, but still the healing abutment is under the gingival margin. I decided to change the healing abutment to longer one, 5, 5, 7 millimeter. Okay, and 2 months and 3 weeks after the operation, the ISQ value increased to 80, 80. So it is enough to start loading. My prosthodontic partner, Dr. Kim, tried restorative procedures, and he used the stock abutment and fabricated a definite restoration. This is final outcome of this case. Okay. Soft tissue margin looks not bad, and this is radiographic image. Not yet. not yet matured around the implant coronal portion, but time will change the remodel the crestal bone, and I expect a very nice prognosis of this case. So this is early implant case. Not so many cases I do early implant. I just do very limited situation when immediate was also possible, but I didn't place implant because of some reason. That is the indication of early implant placement. Then let me talk about delayed implant placement on the mandibular molars. The indication of delayed implant is when it is dangerous or difficult to place implant immediately. I recommend waiting at least 4 months if possible. Many cases I feel, especially when patient extracted tooth because of periodontal disease, 3 months is not enough. Even 4 months looks not enough. At this situation, even 6 months looks better than 3 or 4 months. When it is fresh extraction socket, you can wait 3 to 4 months. Okay. The key point for a delayed implant is first, it is optimal timing to place implant and do simple implant surgery. Immediate and early implant indication is type 1A extraction socket. The others, type 1B, type 2A, type 2B, these belong to delayed implant placement indications. Okay, so many cases belong to delayed implant placement indications. Let me talk about tips for delayed implant after extraction. Soft tissue healing has been achieved and the bone is somewhat mature state. Re-evaluated about 3 months after the tooth extraction and, if possible, wait more than 4 months. In most cases, you do not need to open the flap. Many cases, you no need to open flap. If you really want to increase the attach gingiva, you can try apically positioning flap. Predict the future bone height and place implant in it. Place implant deep, about 4 to 5 mm from the gingival margin. Delayed case belong to 3 to 6 months. Depending on etiology of tooth extraction, the socket healing time will be different. When it is sound extraction socket, we expect very fast healing. However, when it is periodontally affected situation and extracted tooth, we need more time for bone healing. Here is a very interesting article who biopsied the extraction socket periodically in sound socket and pathologic extraction socket. In this article, the result was, as we expected, different depending on type of extraction socket. Sound extraction socket healed faster than pathologic extraction socket. Okay. After 16 weeks, newborn exceeded 50% of total regenerated tissue in socket with severe periodontal destruction. However, in the control group, which is fresh extraction socket, about 8 weeks later, exceed 50% of total tissue. So the healing time is double time between sound and pathologic extraction socket. That means we need more healing in pathologic extraction socket. Patient extracted the left second molar because of periodontal disease. It is taken panoramic view again 3 months after the extraction, and that time when I opened the flap, I found the bone healing very poor in condition. In these pictures, the timing after extraction is 3 months to 4 months and to 6 months. Look at the width of alveolar, ridge, and the condition of soft tissue. Okay. This is ideal time to place implant, and I feel many cases no need of flap elevation because width is not so bad, and many cases has relatively sufficient attached gingival zone. So in such a situation, I can do flapless surgery. Okay, I'll show a case. Here is a 61 years old male patient who missed the right second molar. Okay, the original condition was a type 2B extraction socket. So it is impossible to place implant immediately. So I decided to wait several months after extraction. And re-evaluated the case 3 months later. Look at the right panoramic image. This patient healed very fast than expected, and it looks possible to place implant at that time. So I decided to do implant at that time. Although bone density is not so great, I decided to place implant carefully. Look at the occlusal view of extraction socket. It is relatively wide. Although buccal tissue looks slightly decreased, that's not a big problem. And no need open flap yet in such a situation. Just I performed the flapless surgery. Prep osteotomy as a routine way, and then final drill was 4.5 by 10 millimeter tape drill, and measure the depth of osteotomy site. The depth measured as 15 to 14 millimeter. Okay, buccal 14 and the proximal it is 15. So I selected the 10 millimeter implant and placed implant like this. The depth of implant looks 4 to 5 millimeter. Okay, that means it is enough depth. Look at the video of this case. Okay, it is flapless surgery. So mark the entry point about 5 millimeter distal from the number 6 gingival margin. And I touch the apical bone. It looks in normal bone density or even a little bit hard bone. Anyway, I touch the apical portion. When we place implant at number 7, you must check the path of angulation of implant very carefully, watching opposing tooth, okay, like this. Apical bone was relatively hard. Okay, as a routine way, I prepared osteotomy. There is one question. Okay, early means within 3 months. Early implant means within 3 months. Immediate is within 2 weeks. So 2 weeks to 3 months, it is early implant. I don't like this at that time. Instead, I wait more than 3 months. Okay, this case is more than 3 months after extraction. And I can do simple flap list surgery. Okay. Control the depth and angulation of implant carefully. Minimum 4 mm deep from the gingival margin. Every implant company supply the tool to notice the depth of implant. It is laser marking on that implant driver. The last marking is 5 mm. So I check the ISQ value, look at the enough ISQ value. I can finish the surgery, connecting healing abutment. Okay, this is POP, panoramic image, and the implant is well placed. I like the position and the path angulation and the depth of this implant. Here, 3 months and 3 weeks after the operation, finished the restoration, and the follow-up is 1 year and 5 months after the implant installation. Look at the nice soft tissue condition and the bone remodeling around the implant. 3 years later, look at the stable condition of tissues. Okay, soft tissue healing and the very stable, healthy condition. Look at the bone, marginal bone level. It is well dense enough and stabilized. Okay, and I like such a concave and gradually enlarging emergence profile. Okay. One more case here. This is a young female patient who experienced buccal swelling, okay, left mandibular buccal swelling because of periapical lesion of a tooth. So she received the IND at university because of buccal abscess. Okay. In panoramic image, we can see endodontic treated left first molar, and near the medial root, there are apical lesion which spreaded lowly, and it made a fistula toward the buccal side. Okay. This is type 2B extraction circuit, so it's better to extract the tooth and wait several months. So I decided to extract the tooth, okay, bisecting the roots and then extracted the tooth. I waited the healing 4 months, okay, and look at the panoramic image, not bad. We can see relatively well healed hard tissue also, and in oral intraoral view, ridge slightly reduced in the width about 3 mm and the height about 1 mm. This is usual expectation, just extract tooth and without socket preservation. I don't like socket preservation usually. Even it arises 3 mm bone loss, horizontal bone loss at coronal, and about 1 mm vertical bone loss, but that's not big issue to placing implant at molar site. Original bone width height is sufficient, so even some tissue reduction occurred, still we can place implant without big trouble. So this case, I tried the flap list surgery. This is just after surgery. I can get strong primary stability. Okay, and it's flapless surgery, clean and simple surgery. I want to show a video which taken far away and close view. When we place implant, we do implant surgery. For effective implant surgery, the surgical setting is also important. Okay, the position of an operator and the arrangement of instrument handpiece is also important. Let me show my setting in this case. Okay, like this. Here, I'm in upright position and I positioned 11 o'clock of the patient. And look at my left side. Left side is the surgical table, which keep the surgical tool and instrument. And where is the handpiece? It is on the right side. Okay, right side. And I use Minnesota retractor to make good surgical field. My assistants also use Minnesota retractor. And I control surgical tool by myself. Without big motion, I can control instrument. When it is near and effectively arranged, it looks like this. Handpiece must come from right side and very near to my left side. Every instrument and the surgical tool should be positioned. Okay, it's flapless surgery, so I can finish implant surgery very quickly, like this. Okay. Then let's control depth of implant. Every time I take a video when I do implant surgery. Almost finished. And I check the ISQ value. (81), 83. So it was very strong prime stability. I always check ISQ value during and after follow-up. Here I use the dentist SQ to check ISQ value. Check Q, named Check Q device. I placed the implant the DB knob, so I tried bone profiling and connected healing abutment. It spanned a very short time, less than 5 minutes. Okay. In this video, it is no interruption. It is 4 minutes from starting to connecting healing abutment. Okay, it finished. I found that the position not ideal. Well, it was my mistake. Usually, it doesn't happen usually, but in this case, even I take a video, I made some mistake. I don't like such a positional error, slightly distally positioned. So I decided to change the position after taking panoramic view. I corrected implant position more medially. Changing direction is not difficult. We can easily change the direction of path of implant. However, changing position is not easy. As you see, we will lose the stability of implant, especially when we move minor change. Okay, when we move position greatly, you can get stability. However, it's a very minor positional change. It is even difficult to get stability. XL implant is better than other system in such a point. I move the position slightly, but I can get not bad ISQ value, and I can do one stage surgery like this. 2 months and 1 week after the operation, look at the increased the ISQ value. It increased to 86, 84 from 60s. Okay, it's a big change 2 months later. Again, Dr. Kim continued the prosthetic process with a stock abutment and here scanning and the final restoration delivered to a patient. Okay, this is a radiograph image, and here 5 months after the operation. Nice bone, nice soft tissue condition, and the panoramic image looks not bad. Okay, this is delayed implant surgery case. I performed the flapless surgery. So this is my routine surgery after extraction when it is not indication of immediate. Usually I extract the tooth and wait 3 to 4 months and reevaluate and then do surgery very simply. Mostly it is a flapless surgery. So although I waited several months, the surgical time is very short. Patient feel very comfortable, and the follow-up healing time is also very clean and short. So we can make a nice result with a very simple way. Let me show one more delayed implant surgery case. Patient extracted right second molar 3 months ago, and panoramic image looks like this. Patient has been extracted the teeth at other clinic, and here is the CT view of this patient. Look at the very low bone density, and maybe it was type 2B extraction socket previously. Now it is healed like this. Okay, buccal bone lost some amount, and vertical height slightly reduced. Periapical view is here. Okay, coronal bone density looks not so dense yet. Many cases I do flapless surgery. Maybe if I want, I can do flapless surgery also in this case. However, in this case, I found a little lowly positioned the buccal tissue height. So if I do flapless surgery, I cannot increase the buccal tissue height. So I decided to do flap surgery in this case. Okay, to make better result. Although it's a little bit inconvenient, I decided to open flap in this case. Here I made envelope flap. And look at the extraction socket. It is still incompletely healed. The center is still in fibrous tissue. The periphery is healing in condition. Prepped osteotomy normally. Okay, last drill was at 4.5 by 12 millimeter long set drill, and then here I selected 4.6 by 7.5 XL implant. Carefully control the depth and the path of the implant. I can get 12 Newton centimeter, relatively weak, but ISQ value was 65. I feel it is not bad to connect the healing abutment in such a situation. If you are beginner, I recommend you connect cover screw, but connecting cover screw requires second stage surgery, and my plan to open flap was, my purpose of open flap was increase buccal tissue. Okay, by apically positioning suture. So I decided to connect the healing abutment, and with the apically positioning flap, I will increase labial tissue volume. Because of buccal bone height, it is very lowly positioned. To avoid complex surgery, I decided to place implant deeply. Okay, avoiding thread expose. I need a long healing abutment to make EQ gingival level. And the minor bone graft was done on buccal side. The purpose is not make bone. The purpose is preserve the volume of buccal bone, buccal side. So even I didn't use the membrane in such a situation. Here I performed the modified external vertical material suture, which enables apically positioning flap. Okay, the flap will downward movement instead of coronal movement. Okay, like this. Look at the video of this case. Here you can see buccal tissue defect. With the number 12 surgical blade, I made the envelope flap. With the number 12 surgical blade, I can design the flap at one stroke. And I'm using nice, fine periosteal elevator, P24G periosteal elevator. Although it is not in complete healed state, I prepped osteotomy as normal way. Apical bone is dense enough. So normal osteotomy was done. Increase the diameter of set drills and intermediately check the depth of a hole and the condition of a hole with a depth gauge. Here 4.6 by 7.5 implant was placed. Carefully control the angulation of implant and place the implant enough deeply. If you have any question, you can give a question on chatting window. Okay, maybe it is not necessary to graft the bone in such a situation. You can omit, but to increase the volume, I simply grafted the bone without membrane. And here is the technique of modified external vertical material suture to make apically positioning flap. One more. Modified external vertical material suture was done. Okay, and the surgery finished. POP panoramic radiography image. I tried normal drilling, but the middle to coronal position bone density was not so dense. As a result, insertion torque was relatively low. But I corrected the healing abutment for convenience of apically positioning flap. 1 week later, suture was removed. And 2 months later, we can see nice buccal tissue volume and quality of tissue, buccal tissue. Look at the sufficient attached gingiva on buccal side. Because of apically positioning suture, it increased the buccal tissue volume and keratin tissue. At that time, ISQ value measured at 81. Enough, nice ISQ value. Again, my partner, Dr. Kim, made a crown with a customized abutment. Okay, it was delivered to patient like this. Okay, we can see sufficient keratin tissue at number 7. Okay, I placed the implant deeply, so emergence profile looks gradually widen from deep to gingival margin. Okay. In this case, I performed the flap surgery, although this is not my usual preference, but maybe opening flap and apically positioning suture increased the better result, made a better result than simple flap wrist surgery. Let me change to late implant placement at mandibular molars. Again, look at the timing of implant placement. Within 2 weeks, it is immediate. 2 weeks to 3 weeks early. 3 weeks to 6 months is delayed. Late means more than 6 months after the extraction. The range of late implant surgery is very wide, from 6 months to several years. So, clinical situations can be highly variable. Okay. This is characteristics and the tips for a late implant after extraction. If there was severe bone destruction, bone regeneration can be expected if you wait long enough. You can wait up to a year. After a year or more, after tooth extraction, the bone withers decreased by 30 to 50%. When patients wear denture, it resolves bone withers and height more severely. If there is a lack of attached gingiva, this needs to be considered in late implant placement. Extra short implant is very useful to make surgery simple and easy. Here are keywords for late implant at posterior mandibular molar site. First, attached gingival. Second, depth control. Third, alveoloplasty. And last, short implant. First, attached gingiva. There are controversies in necessity of keratinized gingiva. Some says it is really important for long-term stability of implant. So they emphasize importance of keratinized tissue, and they try to make sufficient keratinized tissue around the implant with a free gingival graft or other means. However, another group says it is not so important for long-term of implant. And they said if patient care the oral hygiene well, there's no difference between enough keratinized tissue or lack of keratinized tissue in the point of implant survival or health, which is correct. It is controversial. Sometimes some patients maintain very healthy condition even without attached gingiva. However, some patients experience peri-implantitis because of lack of keratinized tissue. So there's no absolute answer about this topic. Depending on patient situation, we consider attached gingiva during the surgery. Sometimes I do some special maneuver to increase the attached gingiva. However, sometimes I omit increasing attached gingiva. When I plan to increase the keratinized tissue, there are several ways to increase the tissue. Simple is apically positioning flap. This is simple and effective. Okay, with a simple flap design, doing apical positioning flap and increase keratinized tissue. More predictable way is do free gingival graft. However, it is relatively inconvenient. So not always I consider free gingival graft. This case, who is delayed, the late implant surgery case, about 10 years after extraction. As a result, around the number 7 site, ridge is narrowed and lack of attached gingiva. I tried papilla saving vertical incision, and after placing implant, apically positioning suture was done. So before surgery and after treatment, we can see the migration of keratin tissue to buccal side and apically. So it is not bad. Okay, with a simple way, we can increase the gingival zone and more favorable condition for maintenance. Look at the several cases about laser implant placement. Okay, maybe you can see the here's question about the modified external vertical material suture. Maybe in my case you can see that. Okay, here is a patient who missed the right second molar 4 years back, and it is in completely healed condition. Look at the intraoral view. Number 7 alveolar ridge decreased. Compared to number 6, how much volume decreased? I feel it is more than 30%, almost 50% of bone volume reduced at coronal position. But in number 7 case, I don't consider complex surgery at any situation. Although coronal bone is lost, the middle or basal bone is wide enough, so we can simply manage such a Withers problem. And I do flapless surgery or flap surgery depending on situation. In this case, I decided to do flap surgery. Okay, like this. Okay, envelope flap elevation was done, and about 5 mm distal from the gingiva number 6 marginal ridge, I selected entry point and prepped osteotomy. And it was normal bone density, so I used drill as normally. Final was F4.5 by 12 mm set drill. One more thing I want to tell you is length of drill, in especially mandibular last molar site. To place 4.5 4.6 by 7.5 implant. The length is 7.5. How long drill you will use in this case? You may use 8 mm drill, set drill to prep osteotomy. Possible. Sometimes it is possible. However, the problem is several kinds. First problem is access problem. When we are using short drill at number 7, we frequently experience the interference from the anterior tooth, number 6. The shank of handpiece will touch during the osteotomy, keeping the mesial angulation and advance. Then what will happen? It will touch on number 6, and you cannot keep the correct angulation of drill. And even you cannot prep the osteotomy completely. Okay, that's the first problem. Okay, and second problem is Withers of number 7. Many laid implant case at number 7, bone is not flat. Okay, many bone is like a triangular shape, especially buccal side is much more reserved. So there is a difference of proximal height and buccal height after finishing osteotomy. When you just prep osteotomy with 8 mm stopper drill, you cannot place 7.5 implant because buccal side will lowly positioned, buccal bone is lowly positioned, the implant thread will exposed. Then you have to do GVR to cover the exposed thread. That makes surgery very complex. To make it simple, better to use long drill like this. In this case, I placed the implant 4.6 by 7.5. However, my drill was 4.5 by 12 millimeter. Because of convenience of keeping implant angulation without interference first, and second, I will prep the osteotomy sufficiently deep, considering buccal bone height. Okay? Look at the right slide. Here, at the osteotomy, the proximal lingual bone height and buccal bone is quite different. And I selected the 4.6 by 7.5 implant. It was placed enough deep to hide the thread. Okay. And one more thing I want to emphasize at number 7 molar side is considering opposing tooth. Okay. When time passed along, supereruption of maxillary number 7 will occur. The direction is downward and the buccal side, okay, like this. Okay? Because of the orthodontic force from tongue, number 7 will move buccally. So some patients really too much super elongated and too much buccally positioned. But this case, it is not bad, slightly super elongated. We must control path of the last implant considering opposing dentition. When we just do enameloplasty, then make good direction angulation toward the existing number 7. Sometimes you have to do endodontic treatment and crown and correct the position of maxillary second molar. Then imagine that pass and then try to make good angulation toward the opposing dentition. Okay. Here I place the implant deeply and I can get very strong primary stability. 80 Newton centimeter, ISQ value 84. Once the surgery was done, connected healing abutment. But because of difference of height, proximal to buccal, I found healing incompletely seated. When I connect the healing abutment, when it's completely seated, it stops abruptly, suddenly stop and no more turning. However, when bone interference exists, I can turn the healing abutment with resistance. That means it is incomplete seated condition. To avoid such a problem, I used the bone profiler and I connected the healing completely. Again, I tried the apically positioning suture. It is modified external vertical material suture to increase buccal tissue volume. Okay, like this. Here, panoramic image, the periapical view and the panoramic image looks nice implant positioning. 2 months and 1 week later, healing was uneventful. ISQ value increased to 88. Okay, very strong ISQ value. And using stuck abutment, final crown fabricated and delivered to patient mouth. Okay, like this. Okay, this is my routine number 7 implant case, the late implant case. Sometimes I ignore keratin tissue and do simple flapless surgery, but when I have enough time, I do such an angular flap and try apically positioning flap. Apically positioning suture is not so difficult, but you need some technique for this. If we want a more simple way, I can show you more simple tool to increase buccal keratin tissue. It is using a Lewis button, okay, which is supplied by dentists. It's very simple tool which is connected on the healing abutment. So during the finishing, without tight suturing, we can stabilize the buccal flap with a Lewis button very simply. Here is the case, how the comparison of suturing and using Louis Button. When you try simple interrupted suture, buccal flap will move coronally. So this will reduce the keratin tissue. However, Louis Button will press down the buccal flap and increase the keratin tissue. There are two articles which introduced Louis Button. One article here, number 7's case. The buccal flap was pressed and stabilized with the Louis Button, and the final outcome looks nice. Second article is here. Okay, number 6 maybe. Okay, again, Louis Button was used, and the final outcome is nice. You can increase the buccal gingival zone. Anything is fine. Doing apically positioned suture or using a simple tool, anything is fine. Okay, one more thing is depth control in case of late implant surgery. When we prep the osteotomy, we are using a certain length of drill. So this drill will make certain depths of hole from the bone margin to apical portion. Okay, if it is 10 millimeter drill, actually the length of osteotomy is not 10, it is 11.5 usually. Okay. Dentist drill will create 1 millimeter deep hole from the bone margin to apical portion. Okay. So when we use the 10 millimeter dentist set drill, actual bone hole is 10 millimeter. And the implant depth should be measured from gingival margin, not from the bone margin. So we must add thickness of soft tissue. In case of thin soft tissue, like this, like left picture, it is total 13 millimeter deep from the bottom to gingival margin. Okay, that means when you place implant about 5 millimeter deep, available height is 8 millimeter. When you place 4 millimeter deep from the gingival margin, available height is 9 millimeter. Okay, anyway, even we are using same length of drill, the situation will be changed depending on thickness of soft tissue on right picture, which has a thick soft tissue. Okay, in left side, we measure the total height and select the short implant, 8.5 or 7.5 millimeter. Then the implant is in adequate depth. Look at the right side. When we prep the osteotomy with the same drill, drill depth is 11 millimeter. However, gingival thickness is 4 millimeter. Then, how deep is the hole from the gingival margin? It is 10 or 11.0 millimeter. Okay, that means we can place implant 9.5 millimeter. Okay, so there is no exact relationship between drill length and the implant length. Okay, because the criteria of implant depth is not from bone margin, it is from gingival margin. So before implant installation, you have to measure the total depth of hole and select adequate length of implant. Okay, that's my general way to select implant. And think about the late implant case in mandibular molar site. Some patient has thick soft tissue, right picture, but mostly it is left picture, same as left picture situation. Many mandibular molar healed site, patient has thin soft tissue. So you must use relatively long drill to prepped osteotomy. Okay, here is another second molar missing case. Patient's open bite condition, and it is healed like this. A typical pattern of number 7, slightly decreased the keratin tissue and narrowed ridge. However, middle and the basal bone is wide enough. Simply, we can do alveoloplasty and place implant deep. Because of relatively insufficient keratin tissue, again I tried the lingually placed envelope flap and marked the entry point and the prepped osteotomy and verified the angulation of implant considering opposing dentition. My last drill was F4.5 by 10 mm set drill. Okay, and look at the right picture. Similar as previous case, the buccal bone height and the lingual proximal bone height is quite different. Here I tried alveoloplasty using a crest remover. And then I selected the implant 7.5 mm long. It is short implant. And completely placed the implant inside the bone. Okay. ISQ value 79, 77. Insertion torque 30 Newton centimeter, and I connected the 5 healing abutment. That means the depth is 5 millimeter. Okay, then I can do apically position suture in this case. Okay, then I can show you a picture how to perform modified external vertical mattress suture. Okay, this is illustration of modified external vertical mattress suture. It is better to reflect the buccal flap minimally. That means better to reflect the flap only on the attached gingival zone. Okay, just limit the flap at the mucogingival junction, and then after surgery, let's try apically position suture like this. Pass needle at coronal side to apical side. Okay, it's better to pass the apical needle at attached tissue. Okay, that's why you better to limit the amount of buccal flap elevation, and then move the needle toward the lingual side and just simply pass. Original external vertical mattress suture means we must pass lingual flap same as buccal side, but no need in implant surgery case, so it is modified external vertical mattress suture. Then when you make a knot, buccal flap will downward and apically positioned. Okay. Okay, then here result of apically positioning flap with a modified external vertical mattress suture. I will show the technique with a video. Always I use Minnesota retractors and number 12 surgical blade for incision and lingually placed envelope flap designed. Retract flap only at attached gingival zone. Okay, with the Minnesota retract under the P24G periosteal elevator and prep osteotomy 5 mm distal from the first molar marginal ridge. Drill was 10 mm. Okay, check the position pass and enlarge the hole. 5.0 set drill and the last drill 4.5 set drill and perform the alveoloplasty using crest remover. Here I selected a 4.6 by 7.5 XL implant. The feeling is very nice when I place axial implant because of very sharp thread and good self-tapping ability. I can easily insert and get strong primary stability. Okay, verified implant angulation position with a pass guide pin and check the ISQ value with a check Q. Connected healing abutment. Let's try modified external vertical mattress suture from top to down past the buccal side and the lingual very simply and make knots. Okay, one more modified external vertical mattress suture. After finish, press the buccal flap with your fingers and it will be like this. Here, POP radiograph images, well-positioned implant, and 2 months after the healing, nice condition. So, using a stock abutment, final crown fabricated. Okay. We need enameloplasty on opposing tooth. This is a definitive restoration. And the crown relieved. Like this. Okay. So, when it's such all the missing site, number 7 requires alveoloplasty in many cases because the coronal portion, buccal bone is lost. But simple solution is just to do alveoloplasty and place a short implant deeply. And if necessary, we do apically position suture to increase soft tissue volume at buccal side. Okay, this is another late implant case which performed GBR together. Patient extracted teeth because of a cyst at that area and left mandibular molar site 10 months ago. Now this is healed, completely healed condition on the left mandibular molar site. In panoramic view, bone height looks good. And intraoral picture shows buccal bone resorption. In CT view, I found a relatively severe buccal bone resorption in this case. Okay, so I planned buccal GBR in this case. Although this is not mandatory, I generally do very simple surgery at mandibular posterior molar site. So I have very rare case about GBR. So I want to make some GBR case in this case. Maybe this is a not bad indication. Here, open the flap. It's angular flap. And then I found buccal bone resorption. Mark entry point exactly center of restorative crown. Imaginate the crown size about 10 millimeter, then first implant position 5 millimeters away, then second is about 10 millimeter from the first implant position, and must be checked toward checking the opposing dentition always. When position angulation looks good, enlarge the osteotomy site. Depending on bone density, use final drill. This case, I used normal drill because it looks normal bone. Drill was f.5 by 10 millimeter. And for GBR, I decide to open bone marrow. Okay, before implant installation, better to open bone marrow. Okay, with a round burr. Okay, with a straight round burr, bone marrow opened well, and patient had very thin soft tissue, and when I measured the height, it looks 30 millimeter. So I selected the 4.6 by 7.5 short implant. Better to place implant deep enough. Okay. Okay, it was deeply placed and enough stability I can get. Bone profiling was done to avoid interference of healing abutment with the bone. 557 millimeter healing was corrected, and because I want to do GBL in this case, between healing abutment, difficult to approximate flap in one-stage surgery, I rotated the buccal flap simply. Okay. Xenograft was mixed and prepared a template to design the membrane. When design looks enough well designed, duplicate template to real membrane, okay, like this. And after grafting, cover the grafted bone with a membrane. Okay. Then carefully approximate the flap. Okay. I rotated the flap between the healing abutment. I can get a primary close. Okay. 28 was extracted. This is POP radiographic images. Okay. And CT here. Okay. I grafted the buccal bone some amount and looks not bad. This is 5 weeks after the operation. ISQ value maintained nicely. It is more than 80s. Okay. And the buccal tissue looks well healed. And started prosthetic procedure 3 months and 2 weeks after the operation. And this time, Dr. Kim used the new safe fit abutment. Currently, cementless restoration is very popular in some group. In Korea, there are some dentists who like to use cementless abutment because of a clean soft tissue condition after restoration and easy to maintenance. Okay, here, new safe fit abutment was corrected and scanned the implant. Then with a digital process, definitive restoration was fabricated. Okay. Then delivered to patient. Okay. Looks very clean condition in soft tissue, and in radiographic image looks good. Although it is very short term follow-up, I feel it looks nicely finished. Okay. Maybe GBL is a supplementary process in this such occasion. If we omit GBL, still implant will survive, but to increase the labial tissue volume, GBL will be necessary. This patient is also a late implant surgery case who missed the left molars. It is a 67 years old female patient who missed 36 and 37. Okay. It was lost long years back, and this is a typical healed situation. Okay. The last tooth is number 8, I think, and which is slightly narrowed. Okay. 27 is also not so good condition. look at the CT view. In this case, I can see many old female patient who has very low bone density. Here in CT view, this is D3 or D4 bone marrow density. Okay. Although cortical bone is dense, we place implant beneath the cortical bone, so it is difficult to get prime stability when we prep osteotomy inadequately, and sometimes even implant will dislocate into the mandibular canal, mandibular body itself, okay, not canal. Anyway, this is very poor bone quality. What is your strategy in such a patient? Basically, we have to do under preparation to get stability. Here, open the flap after extraction of left third molar. Okay. Although it is a long extraction site, long time passed, but still possible to place 4.5 implant without big surgery. Okay. Mark the entry point and control the angulation of implant. Position angulation is well controlled. As I expected, it was very soft bone. I decided to do under preparation in this case. Sometimes I do one step under preparation. Sometimes I do two step under preparation. This case, it was very weak bone. I decided to do two step under preparation. So my last drill was at 3.5 by 14 millimeter, and placed implant diameter 4.6 by 9.5. Okay, it is two step under preparation. And the second molar site, the same situation. Another implant was placed. Position pass was nice. And here is the stability and ISQ value. Okay, 36, 20 Newton centimeter, 79, 75, very nice. So 37, 15 Newton centimeter, ISQ value 78, 78. Okay, as you see, with the controlling final drill diameter, we can get nice primary stability. Here I connected a healing abutment, and again I tried apically positioning suture. In these days, I don't do simple interrupted suture at mandibular molar site. I always try apically positioning suture to increase buccal attached gingival zone. And I extracted number 27. Okay, here is a video of this case. Ambular flap designed. I felt it is very soft bone. Okay. The XL implant is nice in normal bone, hard bone, or soft bone also. In soft bone, I can do under preparation, and the cat can get stability with a long pin in XL implant. Here, measure the ISQ value. Okay, then again I tried modify the external vertical material switch. Now you can see the technique well, like this. It is not so difficult, not so difficult. Okay, then I finish the surgery. This is POP, radiographic image. Okay, implant well positioned. However, after the operation, I found depth of first molar implant looks not so good, like this. As you see in this picture, before suturing, depth looks not bad. However, after suturing, look at this. Okay, 37. It is 4 millimeter deep. However, look at this number 36. It is less than 4 millimeter, but 3 millimeter or 3 millimeter to 3.5 millimeter. I don't like this situation because after healing, the gingival height will be decreased slightly. That means final height will be about 3 millimeter or less in 36. So to avoid this, I decide to control depth of that implant. Okay, like this. Just advance further, and then it finished the surgery. Okay, compare the previous radiograph image before the depth control. Look at the 36. It is under the bone surface about 0.5 millimeter to 1 millimeter. After depth control, look here. It looks about 1.5 millimeter deep. Okay, I control depth enough, like this. 8 days later, suture was removed, and 5 weeks later, I-square value increased nicely, and started crown restoration 2 months and 1 week after the operation. Okay, now it is healed condition. I-square value good. Final depth of implant looks 4.5 in number 6 and about 3.5 at number 7. Okay, number 7, but 3.5 not bad. When position angulation is good, it is not bad. Here, Dr. Kim used the stock abutment. When implant position path is ideal, we can use stock abutment and simply continue restorative procedures. Here, final crown made and delivered to patient mouth like this. So, case finished like this. Okay. Sometimes when patient is really poor bone quality and the risk of implant dislocation into the mandibular body, I do bone graft. Before implant installation. What do you think about the short implant? In the past, like many other dentists, I was skeptical and uneasy about using short implant. However, my perspective gradually changed with increasing clinical experiences, and today I have complete confidence in short implant. This is classification of implant length, which is proposed by Dr. Lee. Long implant means more than 10 millimeter, and standard 8 to 10, short implant 6 to 8, and extra short is 4 to 6 millimeter. Until now, extra short implant is available. maybe in the future, ultra short implant, which is shorter than 4 mm, will be introduced, I think, and should be introduced. Some dentists are skeptical to short implant because when we use a short implant, the crown to implant ratio inevitably increase, and many dentists therefore have a concern about their long-term prognosis. However, this concern often arises from applying the biomechanical principle of the natural tooth directly to implant without fully recognizing the difference between them. As you know, unlikely natural tooth implants are rigidly osseointegrated into the surrounding bone and do not have a periodontal ligament. Therefore, the crown to implant ratio does not have the same prognostic significance as the crown to root ratio of natural teeth. So, in clinical practice, an increased crown to implant ratio alone does not necessarily compromise the success of a short implant. Thus, poor crown implant ratio arises crestal bone loss and implant failure because of stress concentration. We worried about this in the past. However, when we look at the reviewed articles about crown implant ratio and implant survival rate, when crown is two times longer than implant, it is acceptable prosthetic options. And another article says implant restoration with the crown implant ratio between 2 and 3 may be successfully in the posterior area of the jaw. So clinically, even we are using extra short implant, which makes a relatively long crown, that doesn't make poor prognosis. So I don't worry about using short implant at mandibular molar side. When patient has insufficient bone height, you can use short implant. Okay, this patient missed the right, it is old bridge condition, which should be removed. Okay, number 45 is not in good condition, so decide to extract the tooth. Number 45, then I will place implant at 45 and 46. Here, after bridge cutting, extracted the premolar, and then immediate implant was done at that site. I used the 4x12 mm drill and checked the depth before implant installation. It measured 16.0 mm. Then available height is 11 mm, but no need to place long implant actually, even it is deep. In this case, I selected a 7.5 mm implanter and placed the implant adequately, slightly deeply, like this. And I prepped osteotomy at number 46. It was very hard bone. There was some condensing condition, condensing osteitis there, so I prepped osteotomy a little bit widely. Final drill, one step, bigger size the drill I used. Drill length 10 mm and implant length 7.5 mm. Okay, here, very strong primary stability I can get. Intrasocket bone graft was done at the premolar site, although this is not mandatory. Because of buccal bone loss, I tried this. Then connected healing abutment after alveoloplasty. Here, look at the enough depth of implant. 45 looks a little bit deep. I changed the healing to 7 mm long and finished. Okay. Extract the second premolar and buccal bone is lost like this. Okay, as you see, there was fistula. Preptosteotomy at center of alveolar ridge, not the center of root. Okay, because premolar root positioned buccally, your implant must be positioned at center. So osteotomy should be done at lingual of extraction socket. Here, short implant I selected. And placed. Okay, I can get stability at apex. Strong primary stability, you can see more than 6 mm deep, I think. Here I connected pass guide pin and then prepped osteotomy for first molar. Bone was very dense at this site, so I have to use the drill with a careful up and down motion to cool the drill and prevent heating. With up and down motion, prepped osteotomy. Patient with very thin soft tissue at there, I must use long drill even I placed so short implant. 4.5 set drill and last drill 5 mm. One step oversized the drill was used. Still implant was very strong. Insertion torque was high. So I decided to prep additionally. Use the last drill and slightly shake the drill to increase osteotomy site. Okay, it was really dense bone. D1 bone is not same actually. When it's really dense bone, we call that kind of bone marble bone. Okay, marble bone, and we need over preparation at that situation, like in this case. I made sufficient osteotomy and finally placed the implant. Okay, because of buccal bone loss, I tried intra-socket bone grafting at buccal side. Connected healing abutment and finished the surgery. Okay, like this. Okay, 1 week later, healing looks nice. 1 month later, very clean soft tissue condition. And here, took impression and crown was made with a customized abutment. Because of slight buccally positioned number 6, Dr. Kim used customized abutment. Okay, here final outcome. Okay, it's here. Short implant, especially very short implant named extra short implant, is very useful when patient experience severe alveolar bone resorption. This is alveolar bone, which hold a tooth root. And under the alveolar bone, we call basal bone. Basal bone. In the mandible, over the mandibular canal, there are available basal bone. And generally, the amount of available basal bone height is 4 to 7 millimeter. 4 to 7 millimeter. When patient experiences severe bone resorption, which means almost complete resorption of alveolar bone, how to place implant? In the past, we considered the GBR, and it's technically difficult, and the prognosis is unpredictable. When we are using extra short implant, such as 6 millimeter, 5 millimeter, and even 4 millimeter, we can avoid the complex surgery. Like this. Here, patient completely lost the alveolar bone. Then only basal bone is available. It is available basal bone. When it is more than 4 millimeter, minimum 4, generally is more than 5 millimeter, then we can place extra short implant. Especially, I prefer 4 millimeter extra short implant, which has 2 millimeter bevel on top. Actual thread height is just 4 millimeter. This is very useful in severe bone resorption case. I have been using extra short implant since 2011, and until last month, total 375 extra short implant I experienced. At early stage, it was 6 millimeter, only it was available. That time I used 6 millimeter implant, and 5 millimeter short implant was introduced. So I used that implant. And not recently, more than 10 years, almost 10 years back, 4 millimeter implant was introduced in the market. I decided to use a 4 millimeter implant. It is my main extra short implant. Look at the numbers of implants I used. Extra short implant, which is just 4 millimeter, is dominant, like this. Now, I just place 4 millimeter implant. When it is not available, I use 6 or 5 millimeter implant. That means my primary extra short implant length is only 4 millimeter. I will show my last case. Although this is not a late implant case, it is early implant case, which is type 1 extraction socket, so immediate was also possible. Periodontally affected mobile tooth with apical lesion. And 2 months and 2 weeks after extraction, it looks well healed. Healing looks very nice. And ridge looks like this. Slightly buccal tissue volume reduced. How much is the available bone height? I can see more than 12 millimeter available bone height exists. However, in this case, I decided to use extra short implant and to increase buccal tissue volume, I made a relatively complex flap, trapezoidal flap, and here 5 by 4 millimeter extra short implant was placed. Okay, I can get strong primal stability and connected the healing abutment. And I tried a very simple roll technique CTG. The epithelialized extra tissue which occupied the space of healing abutment and rolled the buccal flap and increased the volume of buccal tissue. Okay, Okay, here. To do roll technique, I made incision design like this. Okay, I speed up. Prep-osteotomy as a routine way. Okay, the routine way. I will place 5mm diameter implant. So last drill was 5mm. Okay, like this. And here 5 by 4mm implant was placed. Why I placed extra short implant in this patient? I believe in extra short implant completely. And I feel when we place the extra short implant, that's better for long implant when we control any kind of problem. Okay. Short implant is easy to remove. And when there's no problem, it will be there all through the lifetime of patient. When this implant make problem, such as peri-implantitis, we can remove very easily at early stage and replace the new one very simply. Many peri-implantitis persist a long time and resolve bone severely. That makes rescue very difficult. Here, place the extra short implant. Okay, and correct healing abutment. Healing abutment. And I try the roll technique, CTG. Okay, remove epithelium with the blade. And then underlying connective tissue was rolled. Positioned toward the buccal side. Okay, like this. It's a very simple way to increase buccal tissue volume. And here, approximated flap. Okay, then POP radiograph images here. Healing was uneventful, and final outcome here. Okay, this is 1 year and 8 months after surgery. Look at the soft tissue condition. Okay, volume well maintained and looks in very healthy condition. And what about the bone condition? Here, okay, look at the very stable bone. I think this implant will never fail during the patient lifetime. Okay, so it's better to place a short implant, even bone is enough. Okay, in the future, you and me will not use long implant anymore, except the immediate implant place situation. Okay, this is much better than placing long implant. Okay, but the problem is such an extra short implant is limited in diameter because of regulation of country. In Korean Food and Drug Administration says we have to use more than 5mm diameter implant in extra short implant. I think that must be changed. Better to make extra short implant in 4 mm or 4.5 mm diameter implant. Okay, is my suggestion. And here is several questions from Korean and foreigners. Okay, one dentist asked me he couldn't get prime stability in early implant case. Maybe it is difficult to get prime stability in early situation. It is too early, and he connected a cover screw because he couldn't prep the apical portion. That's the usual situation when you do early implant. Okay, he asked me, should I wait longer? Okay. Another dentist also made the answer, yes, you should wait longer than 2 months. Delayed implant is best. In delayed implant situation, even we prep osteotomy in the previous healed bone, depending on the prep diameter of drill, final drill, you can get minimum stability, so you can do one-stage surgery. So in periodontally affected case, I recommend you wait minimum 4 months. Another question. I placed short implant 7.5 millimeter after using long drill. As a result, the depth was 16 millimeter. Then, is it difficult to get prime stability using such a short implant? Yes, that's true. But when I place implant deep enough, still I can get stability. And generally, I use I calculated the implant length minus 5 millimeter, and the similar length available length of implant I use. Sometimes I have when it's not available, I will use a short implant. I don't know exactly why I placed the 7.5, even depth was like that. Maybe the available length was not there was no available length. That's why I placed a short implant. Generally, about similar available length implant is better. Okay. Another question. Extra short implant cases. Okay. Okay. When I use extra short implant which has a 2 millimeter bevel, okay. Is there any long-term buccal bone soft tissue stability? I don't worry about this. Because my implant, generally, when I place extra short implant, always the thread portion is inside of the bone, and it is always deep enough. So there's no influence of soft tissue health or bone condition. Okay. Even the advantage of 2 mm beveled extra short implant is, as you know, when patients experience severe bone loss, always the buccal bone is lower than proximal or lingual. As a result, when you place implant enough deep, still buccal bone is lower. And when I place the 6 mm implant or 5 mm implant, small portion of thread will be exposed. Then, such a rough surface exposed thread should be covered with a bone grafting. I want to avoid this. Even in very less bone, 4 mm implant can be placed deeply and let the bevel portion exposed. Okay, it is machined color. If you want, you can graft, but it is not mandatory. Okay, so it makes more convenient in clinical situation, and the machined color is not familiar to bone, but in soft tissue, it is familiar to soft tissue and doesn't make trouble. Okay, clinically, it is more useful than 5 or 6 mm short implant. Okay, another case here. This question about the mandibular anterior site. He placed the implant in anterior mandibular site and the lingual lingual dehiscence defect occurred. So he tried GBR. He asked me the progress of the lingual GBR. Okay, think about the bone envelope. When we perform GBR outside the bone envelope, always the progress is not good. When it is inside the bone envelope, always it is good. When you try the GBR at lingual side and it is outside the lingual bone envelope, the bone will resolve. And the same in the buccal side. I don't know the exact condition of this, but maybe you made a dehiscence defect during the mandibular anterior to place a relatively big implant, maybe 3.5 or 3 millimeter. In mandibular anterior site, better to use very short, very narrow diameter implant. The ideal is 2.5 millimeter implant. Generally, this one piece type implant. Later, after healing, try to place a narrow diameter implant. Okay. One more question. I recommend to place implant 5 millimeter deep from the gingival margin. When gingival margin height is different, buccal, lingual, or proximal different, where is the standard? Sorry, I forgot about the word. Where is the criteria selecting depth of implant? It is buccal usually. Most lowest gingival margin is the reference point. Okay? From the low margin, place implant 4 to 5 millimeter. Okay? Generally, this buccal. During the apically positioning flap in the mandibular second molar, why don't you partial thickness flap? What about the promotion of full thickness flap? Okay, partial thickness flap is the previous technique to perform apically positioning suture. When we leave periosteum on the bone, we can do apically positioning flap more easily maybe, and more competent, more sure way to fix the flap apically. However, the problem is technical difficulty. Okay, I tried the partial thickness also in the before, but technically it is not convenient. In my experience now, when I do full thickness flap elevation and careful apically positioning suture, it is almost same as a partial thickness flap. That's why I do just a full thickness flap combined with the apically positioning suture. Okay. Early implant case, open flap or no flapless surgery, what's the difference? He said, he asked me, when you open flap, if I don't open flap, I don't do GBR. He said, even in early case, in flap surgery, still you can omit GBR. Oh, that's true. That's true. Even we open flap, when the condition not bad, we omit graft. My point is, in severe bone destruction case, such as a periodontally affected case, that situation, defect looks very big. That time you have to do GBR when you open the flap. When it is minor case, even open flap, you can omit graft. But that case, such a minor case, no need open flap. It is inconvenient. Okay, it's very simple situation to do flapless surgery. So the point is not graft or not. Okay, early implant indication is same as immediate implant in simple case. So simple case means no need of flap elevation. Okay, in case of severe periodontal defect, don't try early implant surgery. that requires extensive GBL when you place implant, and maybe that require flap elevation. Okay. Okay, I finished the question and my lecture. So it is time out. Okay, thank you very much for your kind attention. And I want to see you 2 weeks later. Thank you very much.